So I'm going to talk about the pelvis because reduction techniques are probably somewhat more forgiving, although we've seen issues already this morning with even small residual malreductions. I'm going to show you one relatively simple tool and then one which is, falls in the realm of more fantasy. So this is now commercially available. This is an anterior sacroiliac joint reduction aid, and I'll show you how it's applied. It essentially replaces an anterior plate in this position. So there's a screw placed in the pelvic brim. It can be either on this internal surface or slightly more cranial here, and it has a foot with two teeth on it, and basically the screw is put through this slot so that the screw will then be allowed, essentially it will slide down the slot, and you can use this arm as a lever to translate the innominate bone anterior and distal. So it essentially replaces and get the single plate as a reduction aid, and it gives you another plane of stability. It's a relatively simple tool. It's an idea that was refined from something that Jeff Mast provided with us a couple of years ago. I think that is, particularly for anterior approaches, very, very useful, and it's amenable to either plate or iliosacral screw fixation from the front. Now, fanciful. What is this? This is the alpha version of the so-called repo or repositioning aid. This is these are essentially two human hands with the strength of the Terminator, basically. And so these are, if we look at the business part of this device, it is essentially a mechanical hand which has 6 degrees of freedom. And so it can perform all the functions of an upper extremity, and it can do it with a tremendous amount of force. These are small servo-controlled motors which can generate in excess of 200 pounds of force. So it's an engineering marvel in and of itself, but the applications are essentially for controlled reduction. And whether or not they're used with open or closed procedures is certainly a flexible situation. And here is the view from the side. It will attach to a standard table. And then the control panel is here. So there is essentially a graphical user interface. And in this situation, we can see the sort of space station control. The exact form of the final manipulation is still undergoing transition. We're trying to figure out what is the best graphical interface for people to use. And this is just one application. So this is in the pelvis, in a situation in which we have on this side a stabilization. So in this case, we have an arm on this side and an arm on this side, and they are capable of independently moving relative to each other. In addition to, if we go back to it in this application, you can actually define a hip center rotation, and you can reduce this and then flex the hip and maintain the reduction. You can also internally and externally rotate the hip without disturbing the reduction. Don't ask me how. It's a software problem, okay? So this is what it looks like from the side and the graphical interface. So this is the first trial of this device. So the interface as far as the skeletal stabilization is still relatively crude. They're shank screws. Maybe that's going to be the final form. So percutaneous shank screws in the supraacetabular area and ilium. This is the disruption which was created, so a sacroiliac joint and SI joint. And then using this graphical interface and the arms relative to each other, there's the shank screw placed. And we can see the other screw coming in from the medius pillar, and the other side is stabilized as well. And so a progressive reduction done only with the graphical interface, and a progressive reduction, and then percutaneous screw fixation. So there are a number of inputs that have to be managed as far as force application, and this is still a software challenge as that's concerned, but it's been evolving relatively rapidly. The ideal situation for this would be an interface in which you can combine a computer-assisted implant insertion and reduction aid without the use of segmental or multiple fluoroscopic views. Now, we've been installed with computer-assisted use in the pelvis for many years because of the difficulties with surface registration of two targets of complex morphology and then carrying out a reduction. That still is not possible. We're 20 years into this, so I don't know when that will be available and can be mated to this system. The acetabulum, just a couple things. This is a reduction aid, I think, and it's also a quadrilateral surface plate designed for standard approaches. So it's a plate which is designed to be placed along the quadrilateral surface and then is coupled to a percutaneously inserted cable system, which will then pull laterally. So you can see we're waiting now for the cable attachments to essentially help us with this. But eventually, you can see that you could use this as a reduction aid for the quadrilateral surface in those rare cases where there are articular involvement. It also will act indirectly as a posterior column reduction aid. It will laterally displace the posterior column, and it's probably going to be useful even in cases of relative osteoporosis, which is the most common fracture pattern that we're seeing with these. And then lastly, I've already shown you this. This is probably the second easy thing to get. First is a sacroiliac joint reduction. The second is no matter which approach you've seen over the course of this week, the underlying theme of stable lateral distal traction will help you. It will help you for Marius's approach. It'll help for every other approach as well. And this is a cheap device. This is basically a femoral distractor and a table attachment. It can be attached to anything. And as far as one thing that will help you with this type of surgery for the acetabulum, in some cases it'll give you indirect reduction of the posterior column or anterior column if the fractures are complete and you're doing it early. Other times it'll just help you by repositioning the head. And you can adjust it as many times as you need to intraoperatively. So two cheap examples of things that can help you. As a final point, I don't know if you can read this, but this says pan 4. That means there are 3 pans in addition to this. These are instruments, these are reduction clamps that represent 30 years of prototypes. And one of my favorite stories about Emil was that he was extremely tolerant of new ideas. And we would always have a lab with him where we'd operate with him, and somebody would describe a plan for a clamp that would fit here, 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 here. And he'd say, yes, I think we have that. It's sleeping on the back table. And virtually every conceivable configuration for a clamp he'd already gone through and was sitting in a pan very similar to this one for mine on the back table. So the search for the perfect clamp for each fracture through every approach goes on. And ultimately, the idea of modular clamps and the adaptable clamp, which will fit any given situation, persist, but it may persist only in the form of mythology. So with that, I will leave you. That's all we have as far as progress at this point.